Coming up this week on Success Won't Come Calling.
The trouble with social media, there's not a sort of sensible filter. You need a common sense algorithm filter. This is utter nonsense. It should be rated. 1 out of 10, this is just rubbish. 9 out of 10, take notice of this. I don't know how the hell you do that, but you've somehow got to balance the good things about social media and what is a lot of nonsense on social media, a lot of damaging nonsense. What I hate is people who come out with one opinion, get totally vilified for that opinion. Perhaps I sound old-fashioned at this point, but a little bit of good manners on social media doesn't go amiss either.
Hello, friends. Simon Gibson here. Welcome to SWCC. If you like the podcast, please click subscribe and you'll know at the moment every one of our episodes lands. Since 2018 in the UK, it has been lawful for specialist doctors to prescribe cannabis for medicinal purposes. It has been recognised to be particularly useful in epilepsy, treatment of anxiety, and also the treatment of chronic pain. I wondered what the future was for this particular medical treatment, also what exactly the benefits are and what the risks are, and how it can help people achieve their goals who are faced with these really challenging conditions. I need some expert help to navigate me through the issues, and I'm delighted to welcome my guest this week, who is Professor Mike Barnes. Professor Barnes is a neurologist. He's widely recognised as the UK's leading expert on the medical use of cannabis. In 2016, Professor Barnes prepared a report called Cannabis, the Evidence for Medical Use, that was widely recognised as being an influential contributing factor in the government's decision to classify the medical use of cannabis differently. And in 2018, Professor Barnes was the first medic in the United Kingdom to sign a prescription for cannabis to be used by one of his child patients. More of that later. Now, Professor Barnes is founder and chair of the Cannabis Clinicians Society, which is a not-for-profit organisation which helps other doctors understand the benefits and the background of cannabis. Finally, Mike is the Cannabis Industry Council founder. This is a trade organisation which brings together different organisations and businesses with a view to, in due course, having a legal production and manufacture cannabis sector in the United Kingdom. Mike, how are you, sir? Welcome to the podcast.
Great, I'm fine, and thank you for asking me. It'd be a pleasure to have a chat through these issues.
Well, I mean, let's get stuck straight in, because I mean, you've been interested in the medical use of cannabis for some years. How did you first become aware of its potential benefits?
Well, it's amazing, as you kindly said in the introduction, I'm a neurologist, and going back now pretty well 20 years, actually. I was doing clinics for people with multiple sclerosis up where I live in Newcastle upon Tyne. And guys were coming into the clinic and telling me spontaneously that they'd discovered cannabis for their multiple sclerosis. It was helping their pain and their muscle spasm, it's called spasticity. And so just very informally, I asked everyone turning up to that clinic, which is about 60 odd people with multiple sclerosis, are you using cannabis? And somewhat really to my surprise in those days, about half admitted to using it. I don't know how many didn't admit to using it, but about half admitted that. And I thought, well, there must be something to this, because, it was criminalizing themselves. It was illegal, and partly is illegal now, of course. So I thought, well, they wouldn't criminalize themselves. And these are often severely disabled people, not easy to get illegal cannabis for them. I thought there must be something to this. So I looked into it a little bit. And then by chance, because of my work with spasticity, muscle spasm, I was asked by a company called GW Pharma to help them develop what turned out to be the first cannabis medicine called Sativex, which is still around, a licensed medicine. So I helped with that. And that's what got me into the sector, really. Then there was a bit of a hiatus for about a good decade because NICE, which I'm sure your listeners will know, is the National Institute for Clinical Excellence, which looks at the cost effectiveness of all medicines. They said Sativex wasn't worth couldn't prescribe it, it wasn't worth it in terms of cost effectiveness. So not much happened in the cannabis space in the UK for about 10 years before before the report in 2016, which I'm sure we'll talk about from 2016 onwards. But that brings you up to 2016 anyway, in terms of my own journey.
Well, that's interesting. I mean, particularly the first identification you made of the potentially therapeutic benefits of cannabis was via patient feedback. When you're treating patients, how relevant and important is that feedback in developing your knowledge and decision making in the future?
I think it's absolutely vital, and cannabis is the primary example, I think, of a patient-driven progress, if you like. It's mainly the patients, and I'm sure we'll come to them, the advocates, people like Anna Deacon with her son Alfie, changed the law, and they are still the main driving force of educating doctors. And as again we'll cover, I'm sure, doctors don't really know much about cannabis or cannabis medicine. And it's the patients who come and say, how about cannabis, and educate the doctors. Not everyone's right. You can read a lot of good stuff on the internet and a lot of rubbish on the internet. But generally speaking, this has been a patient push that has legalized cannabis and continues its rollout, if you like. And I think that's really important. And cannabis particularly is a very personalized medicine. It's not something you say to the patient, here's a tablet, take 1-3 times a day and it'll help your blood pressure. Go away and come back in 6 months. This is a very personalized medicine that needs a lot of interaction between what it's doing for the patient and what the doctor wants to prescribe and feels like prescribing. So the doctors need to listen, and that's a fault of not all, of course, but many of my colleagues. They don't like being told by patients what they might like to prescribe. It affects their power base, I suppose you could say.
I see, because of course you did write the first prescription in the UK following the changes in the law, and you mentioned Alfie Dingley, who of course was your first patient who received that prescription. Tell us a little about how you met Alfie and obviously his family, and how the treatment through medical cannabis was relevant to his condition.
Yeah, it's a great story actually. It's one that needs it needs writing about in due course. Alfie, and just to reassure me, his mother will not mind me mentioning him. Alfie Dingley, his mother Hannah Deacon and his father Drew Dingley. Alfie he's now aged 10, but of course he was probably how long ago was it? About 6 or 7 at the time. He has a very rare condition called PCDH19. He's actually the only boy in the country with this condition. It's mainly in girls, but even in girls it's very rare. And Alfie does have some other learning disabilities, relatively mild, but nevertheless he has them. But the main overriding concern was his epilepsy, and he had 300 to 400 seizures every week, totally resistant to licensed medications. He tried virtually every anticonvulsant in the book. Nothing was helping. The only thing that helped was he had to go into hospital and have intravenous steroids, which is not a good thing for anybody, let alone a child. They're the only things that stop them. But he was admitted, for example, to hospital 48 times in the year before he tried cannabis in intensive care, let alone the distress for him, the distress for the family, and of course the cost. We shouldn't forget, about £3,000 a night to be admitted to pediatric intensive care. So, it was a dire situation. The family's quality of life was very poor. So in desperation, his mother looked into this and looked at support groups from the States. And there was early reports from the States that cannabis was helping some of these children, not all with his rare condition, but other associated childhood epilepsy conditions. And it wasn't available in the UK, of course. So the family went across to Holland, where they lived for 6 months, at great cost, and couldn't work, of course. They were living in a caravan park near The Hague, and where it's legal across there, that's why they went. And Alfie tried cannabis. Nothing much happened for about 6 weeks. It was under the direction of a Dutch consultant. But then all of a sudden it started to work. And over another 3 or 4 weeks, the seizures stopped. Remarkably, really. I mean, from going from 300 to 400 seizures a week to none is quite extraordinary when all other medication had failed. So they obviously didn't want to live permanently in Holland. Their home was in the Midlands. Came home. and launched a campaign with the help of an organisation called End Our Pain, who are run by two parliamentary lobbyists, Peter Carroll and Will de Paya. And ultimately, that was a very successful campaign, which I think it's fair to say that was resulted in the law change in November 18, which we'll probably come to. But just to focus on Alfie for a minute, he had a few breakthrough seizures about 2 years ago for about 4 or 5 months. We nowhere near as bad as they were, but we changed and adjusted and fiddled with the cannabis dosages and different combinations, and eventually they came under full control again. And now he's been seizure-free for the best part of 2 years. And of course, that's not just no seizures and no admissions to hospital. It's he's now back at school. He's learning. His physical control is better. He can ride a bike. He can ride a horse. He's learning at school, which he didn't do before. And the whole family's quality of life has immensely improved. And another example, Hannah, his mother, was his main carer on benefits, and is now she's earning money. She runs the Mapletree Medical Cannabis Consultancy with me, and she contributes to society now, where before she had to just look after Alfie. So it's been a remarkable change for Alfie and his family, I have to say, and that's a great example. And not everyone who takes cannabis, it shows that remarkable improvement, but it just shows you what cannabis can do, and it's a great story.
Wow. It's difficult to know where to start there. I've got to give Hannah such a lot of credit, first of all, for researching this potential solution. In the research I've done, Mike, what has surprised me was looking back at the sort of history. It did seem that there was quite a lot of international studies which supported the therapeutic benefits of cannabis. I mean, you mentioned the USA, where I know it's widely accepted for a long period of time, the benefits, and elsewhere in Europe. Was there any degree of ignorance, or dare I say it, snobbery amongst the sort of clinical community or the governmental community in terms of acknowledging the data and the studies which were provided elsewhere in the world?
Yeah, well, first, you're absolutely right. It's been legal in parts of the states for good, I don't know, about 15 years now. In California, even a bit longer. California, Oregon, Colorado, 35, I think, of the states in the US are now legal medically, and some recreationally, of course. Canada, Uruguay, parts of Europe. And there wasn't that much evidence going back 20 years because it was illegal generally, and it was therefore difficult to do research on it. Not impossible, but very difficult. But now there's, to put a number on it for you, when I did that report for Parliament that you mentioned, there was around 20,000 papers at the time. Now, that's a pretty good number, clinical papers, but there's now about 40,000. So our knowledge is going up dramatically. But you're quite right, sadly, and I have to criticize some of my fellow doctors in the UK, or the British doctors generally like British evidence. And that's you can call it what you like, snobbery or whatever. And I know then Hannah came back to the UK, mentioned to a very eminent paediatric neurologist in the country about the evidence from the Dutch studies that have been done to enable the Dutch doctors to prescribe. And she said, well, they're Dutch, aren't they? And I find that extraordinary. It's not as though the rest of the world is doing rubbish research. This was good quality work done across the world that has largely been dismissed by most of the British medical hierarchy, which I think is remarkably sad, stupid, narrow-minded. I could go on forever, but I think that's, let's look at the global community that's doing more about this. I criticize the papers they're produced, sure. I mean, some papers will not be very good in a research quality, but it doesn't matter where they come from. If you've got a good paper that's research quality, let's look at it, wherever it's come from. And sadly, British medicine tends not to do that.
So this wasn't a cannabis-specific issue. You believe that this is a feature of, or certainly it was then, a feature of British medicine, that perhaps they were a little conservative with a small c?
I have to sadly again agree with that. British medicine tends to be very conservative. I'm not familiar with every branch of medicine, clearly not, but certainly in neurology and in cannabis particularly, we are very insular and very just only trust the British medicine. We might just about, sneak in the odd British-speaking country sort of research with some reluctance, but anyone who doesn't speak English, that we can forget. I'm being slightly cynical there, but, there's an element of truth behind that.
It does seem remarkable, doesn't it? Because it seems to me to run contrary to the basic principle of treating patients, that you should analyse all of the evidence available before making clinical decisions, and then bring them into force.
Exactly. I think a doctor has an obligation to do what's in the best interest of their patient. That's exactly what their obligation is, and to do that, if some of the work has been done in Germany or Holland or wherever, look at that, understand it, and then make an informed judgment and decide what is good for that patient, regardless of where the evidence has come from, as long as it's good evidence.
Yes. Talking of evidence, you prepared in 2016 your paper for, was it prepared for the Cabinet?
No, it was a Parliament, as I'm sure you know, have a number of all-party parliamentary groups. They're cross-party groups to addressing particular issues with the aim of influencing government and producing reports and papers that inform the legislation that may follow. And there's one called APPG, it's called on drug policy reform. And I was asked, it was for them that I was asked to do this report, led then by Baroness Molly Meacher and a couple of MPs, Antonio Antoniazzi, now led by her and Alberto Costa, I believe. So they have to be cross-party. It can't be just one of the political parties. It has to be House of Commons and the House of Lords involved. And they were the guys that asked me to do the report, which I did in 2016 with my daughter, actually, Jennifer Barnes, who's a psychologist. She wrote some of the psychological aspects of cannabis treatment, and I did the others.
And how did you approach the paper in terms of presenting the benefits of medicinal cannabis alongside its risks?
Yeah, I think, well, looking back on it, I think I was almost too thorough, which may be a funny thing to say. But what I mean by that is I looked at the evidence as a pharmaceutical product, which it isn't. And now I think I would have approached it differently. But at the time, I looked at the evidence. If they'd done double-blind, placebo-controlled studies, and that means, as I'm sure you're aware, you have to compare an active compound with a placebo. Yeah. It has to be blinded to the person who gives it and to the patient, so everyone doesn't know what they're taking, and then you compare the results in the two groups, crudely speaking. That's the standard, the so-called gold standard for a new pharmaceutical product, a new antibiotic or a new blood pressure pill or whatever it is. So I looked at the evidence from that point of view, and was really quite rigorous about assessing that evidence because I knew the paper would be scrutinized and probably criticized. So I was pretty firm about saying that this indication has good evidence behind it. It had to have at least two of those studies, it had to be backed up by some theory and some other papers. And we came to the conclusion there were 5 conditions that had, on that basis, had good evidence. I broaden that these days. I don't think I would have done it exactly the same way because cannabis is not a pharmaceutical product, it's a plant, and you need to look at the real-world evidence, as it's called. Perhaps we'll come to that, not just the double-blind, placebo-controlled pharmaceutical approach. But nevertheless, with that approach, we found and determined there was good evidence for pain, anxiety, epilepsy, nausea and sickness in the context of chemotherapy, and spasticity. Muscle spasm. And then we were very careful, of course. Any medicine, you need to determine what's good about it, but you also need to know what's not good about it. And you've got to balance the risks against the benefits. And so we look carefully at the risks, and there are risks. It's not right for everybody. So I hope and believe that the paper was balanced. It was very honest about the risks. It was very honest about the benefits, and came to, I hope, a balanced conclusion. And it actually hasn't been, to the best of my knowledge, particularly criticised. So hopefully we got that right.
It's interesting, isn't it? We talk a lot about risk on the podcast because quite often achieving goals does involve that balancing of risk against potential reward, i.e.
Yeah.
What is the reward you get from moving from situation A to situation B, and what are the risks involved in getting there? And does the B justify those risks? It always seems to me that from a medical perspective, a lot is asked of in terms of innovation when new procedures, new medicines, new theories are brought into play. Is there a particular formula you follow, or which medics follow, to balance that risk and reward?
There's not. I think medics in this country look upon governmental bodies to do it for them, and the main one that does it for them is NICE, the National Institute for Clinical Excellence. And they do a good job. I don't want to criticize them, but they do look upon it. The other dimension they bring in is the cost. And that's not in any way unreasonable in a cost cash-strapped National Health Service. If you introduce a new drug that costs a lot of money, you've got to think, well, is it really worth it for the benefits it accrues to how many people? I accept that entirely. But otherwise, we have to rely basically on what the drug companies tell us about the risk and the benefits. Which isn't necessarily good, because clearly the drug companies are quite rightly and understandably pushing their own products. And we know now, from, for example, the opioid crisis, particularly in the States, that there are some less scrupulous drug companies that push their own products and sort of bury or play down the risks associated with them. So I don't think in this country, or most countries around the world, there is a real mechanism for assessing what is a good medicine, a new medicine that's a good medicine and what the risks are of that, without bringing in the economic dimension. That's a valid thing to bring in, but I would prefer to say, well, what is this medicine good or not good for what sort of population? Then it's up to the politicians to put the economic spin on it and say, this is great, but we can't afford it, and be honest and open about it. That's what I like to see. But I'd like the NICE deliberations to be separated from the economic deliberations, because I think that's a political agenda, whereas we as doctors hopefully just want the medical agenda. Is it good? Is it harmful? Who's it going to help? And finish.
Yes, because I mean, that ultimately is what you have to do when balancing any sort of risk, isn't it? It's about looking at the evidence, looking at the potential outcomes, and really deciding with balanced judgment whether the reward justifies the risk you're taking. I mean, that isn't just a clinical situation. I do that in business. People do it in life. And I think without clarity on the evidence, it's ever so difficult to make that balanced judgment.
It is. Yeah, I think we need an unbiased commission, panel, call it what you will, that looks at these new products and doesn't look at the economics, but looks at their safety and their efficacy and tells us that, and then pass it quite openly, transparently to the politicians to say, this is a good drug, but I'm sorry to say it's going to cost whatever, £100,000 a year. We had some in the press recently, haven't we? Drugs helping just a tiny number of children, which is great for them at a hugely high cost. And it helps those children. I don't going to comment on that, but can we afford it when we've got a limited economy? That's a political judgment. And I hate to see the evidence for a good quality medicine being clouded by that economic judgment that's put on it. I think that needs to be a separate process.
That makes complete sense. You mentioned the 5 conditions which you identified could be helped therapeutically through the use of cannabis: pain, anxiety, epilepsy, nausea arising from chemotherapy, and spasticity. Yeah. Do those conditions share anything in common in terms of their causation or symptoms, anything like that?
Well, that comes back to how cannabis works. And you can read those conditions, think there's no link to those. And some would, and there's other things that cannabis does, like Crohn's disease and a whole variety of other things, apparently not linked. It's anti-cancer in some ways. It helps a lot of different diverse symptoms from a lot of different diverse diseases. And some would turn around and say, well, it can't be. It must be a snake oil. How on earth can it do that? Our brains are programmed for pharmaceuticals. A new antihypertensive drug helps reduce blood pressure, and that's it. A new antibiotic, attacks bacteria of a certain type, and that's it. Well, but this drug, it has anxiety on one side, pain on the other, and epilepsy on another. Apparently no links. how it does that. When you understand more about cannabis, you understand why it does that. And it works through what's called the endocannabinoid system. And without getting over technical, all of us, all vertebrates actually, not just man, have an endocannabinoid system. We produce our own cannabinoids, cannabis, if you like, in our own brains. Chemicals called anandamide and 2-AG and others. And they link with cannabis receptors in our own brains and spinal cord and across the body. Wherever there's a nerve in the body, there is an endocannabinoid system. And that the nerves subserve all our functions, from eyesight to hearing to bowel to bladder to sexual functioning to pain, tingling, whatever it is. So the endocannabinoid system is associated with all those nerves. And what it does, it's a sort of modulator of those nerves. It's a sort of negative feedback loop. When a nerve is switched on, it needs switching off. And the endocannabinoid system helps to switch it off. So it controls the balance in the body across all nerve function. It's the most important so-called neurotransmitter system in the body. It is not widely taught at all in medical schools for reasons I find bizarre. But come back to the question, the cannabis works largely, not totally, but largely through that endocannabinoid system. And if that symptom helps bladder and mind functioning like anxiety and brain functioning like epilepsy and pain, then of course the cannabis helps all those functions because it works through this overarching system. That's why it has such a range of uses. So the link between those things is that they are subserved, modulated, helped by the endocannabinoid system, and cannabis in turn helps the endocannabinoid system.
Right, I think that's the key, isn't it? Does it make the endocannabinoid system more efficient? Does it does it make it more efficacious? What's the basis of that?
Very good question. It's thought, and this is an area now that's more speculation than fact, that we're all born with a different amount of endocannabinoids. And some are more deficient in endocannabinoids than others. We know that's the same, for example, with Parkinson's disease, when a neurotransmitter I'm sure many have heard of called dopamine is deficient. Some people are born with more, some people are born with less. It declines over time. And so for that particular system, you give people dopamine and it improves or helps their Parkinson's disease. It's the same thing, in my view, with endocannabinoid system. Some have a relative deficient or relatively malfunctioning endocannabinoid system. And cannabis externally is just like taking a dopamine tablet for your Parkinson's disease. It balances that system that is out of balance, if you like.
I'm with you. That's so interesting. Let's move on to the practicalities then, because I guess there could be people watching and listening who are thinking, who are in situations where they're in pain, where they're suffering from anxiety. There might be an epilepsy issue in the family. What happened, first of all, in 2018 specifically to change the rules on this? And then I suppose second question, in light of that rule change, what should people do if they are in some way affected by these conditions, which it's been found that cannabis can help with?
Yeah, well, the law change really came about as a result of Alfie and Hannah's campaign. It's a very successful campaign. Again, it's a marketing campaign that needs to be written about at some point. As a result, and pretty well all actually, the newspapers, radio, television were behind the campaign. You couldn't help but be behind the campaign. No one in their right mind would say little Alfie, who's been cured of this cannabis in Holland, shouldn't deserve to have it in the UK. It's a very successful campaign, as a result of which the law was 6 months after he got his prescription. He got his prescription in June 18. In November 18, 5 months later, the law was changed by the then Home Secretary Sajid Javid, and a great credit to him and his ministerial staff, and the guys at the Home Office actually were remarkably helpful in helping me to do all the right documents to change the law. So the law was changed on the 1st November 18, quite liberally actually. I think that's widely known. A doctor now can prescribe for any condition. So it's not just those 5 things we've talked about, pain, anxiety, etc. It's for any condition for which that doctor feels that it's in the best interest of the patient to prescribe it. Now that's unusual and probably more liberal than most countries around the world. They restricted the prescription to be initiated by a specialist doctor, a doctor on the so-called specialist register of the General Medical Council. That's mainly a hospital consultant. So GPs can't start the prescription, but they can carry it on after the consultants initiated it. I think it's a bit of a disadvantage, but again, it's a sort of fine print. It means we're excluding half of the medics in the country from starting this off. So that's the legal situation. And that was great. It was a great day. I thought, that's it. I can now retire and go in and do something else. Sadly, that's not the case, because for reasons where I'm very happy to explore with you, there's only so far been 3 National Health Service prescriptions. 3. One for Alfie and 2 in Northern Ireland for 2 other young children with epilepsy. All the rest of the prescriptions are in the private sector. And that's because the NHS has been incredibly reluctant to embrace this. Legally, they can. An NHS consultant can sit in a clinic and hospital and write a prescription for cannabis. Perfectly legal. But he or she's got to jump through many hoops to get it approved. They've got to get it approved by the trust, their hospital trust committee, usually called a Drug and Therapeutics Committee, or the medical director, who are generally reluctant about embracing this dreadful, stigmatized hippie drug. And there's still that stigma around. And some of the august medical bodies have come out against it, like the British Pediatric Neurology Association for Children with Epilepsy. They're implacably against it. And that hasn't helped. Then there's been funding issues. I remember Matt Hancock, who was then the health secretary, said if a doctor wrote a prescription, he'd personally make sure that there was no funding limitations, that it would be funded if a doctor made that decision. That has sadly not happened. And for all those reasons, it's now, you've got to really effectively go through the private sector to get a prescription. About 12.5, pushing 13,000 people have now been prescribed, all bar 3 in the private sector, which is very sad. A, that's not needed, and B, it's still quite expensive. When you add in all the private consultant charges, you have to pay for the medicine out of your own pocket. Initially, some of the families were paying up to £2,000 a month for medicine that helped their children they should get for nothing. It's now a little less. It's £1,000 to £1,500 a month. Children need more than adults, ironically. Adults with pain are forking out about average £300-400 a month now, plus the consultation charges. And there, a lot of people simply can't afford that. And anyone, it's expensive. And that's so sad, because it's not legally necessary to do that. And there's a lot of reasons for that, but it's a rather sad situation. So Sajid Javid changed the law, and ironically, he's now the health secretary. So I really do think he should see through his own law change and make this much more readily available. So ironically, he's the one who now can influence this, not entirely, but he can influence the easier prescription of this.
Yeah, to reduce that bureaucracy. Let's just walk back through a few of the points, because I found some that's quite shocking, Mike. Did you say that the British Pediatric Neurology Society were opposed to medicinal cannabis?
Yes,
and
they are.
What do they say about Alfie's case?
That's a very good question. They say I won't confuse things too much. There is a licensed cannabis medicine called Epidiolex, which is pretty well pure CBD. Now, again, I have to backtrack slightly. Cannabis has 2 main cannabis components: THC, the one that gets you high, and CBD, the one that doesn't get you high, but it has medical properties. This stuff called Epidiolex is pretty well pure CBD, and it's CBD that is mainly the anticonvulsant. Now, they've made a medicine, licensed medicine. Good luck to them. Absolutely excellent. They will push the boundaries. And some of the pediatric neurologists will prescribe that. The trouble is, it doesn't help all the children you prescribe it for. And you therefore need to move on to an unlicensed cannabis product. They're called full spectrum products. And then basically the difference is that contains all the other little bits of cannabinoids that are in the plant and other things in the plant called terpenes to give it its smell, but also add to its medical properties. So you move from the pure Epidiolex, which works for some, but not for everyone. And that's that jump that BPNA, the British Pediatric Neurology Association, don't like. They say there's not enough evidence for us to prescribe these full spectrum products. There is evidence. There is a very considerable amount of evidence now, but it's not, coming back to what we talked about earlier, it's not in the sort of double-blind, placebo-controlled pharmaceutical model. And they're stuck. Their mind is stuck in that paradigm. And I think that's rather sad. There's not enough evidence. There never will be enough evidence if you treat it as a pharmaceutical. We could be waiting. We could have this discussion in 10 years' time. And they won't have moved because there won't have been more studies, because you cannot do those studies on the plant as if it's a pharmaceutical product. Full stop. They don't seem to understand that. They also can't seem to understand the balance. You've got a child having multiple seizures and multiple pretty poor licensed anticonvulsants, because they're not doing the trick, with side effects and damages to that. Multiple seizures are harmful. But they said, no, let the child continue having seizures, because there's not enough evidence to try cannabis, which we know works for about 80 to 90% of children who try it. That was a remarkable statistic, but it's true. And we know it's pretty safe. It's not right for everyone. It doesn't work for everyone. But for most, it works and it's safe. So the BPNA peculiarly say, let the child carry on having seizures, the damage from the seizures, but we won't let them have cannabis, which might help them. I find that, I don't understand. I genuinely, Simon, don't understand it. What is the mindset that enables presumably a caring doctor to come to that bizarre conclusion? So I've argued with them publicly, and they seem implacably against it, and for reasons I don't get.
So with their point, and I guess this would count for the other doctors who themselves were reluctant to prescribe, is it because they view this as, because I guess there's three things we've talked through. Number one is a lack of evidence. Number two is the risks of the drug, of the medicine, which are revealed by what evidence there is. And then the final thing is this stigma that could exist.
Yeah.
Which of those have you encountered as the biggest barrier for medics to be willing to prescribe and embrace this as a treatment?
Yeah, I think the main overt barrier has been their view of the lack of evidence. And it's because they've looked upon it, as I've said a few times now, as a pharmaceutical, and they haven't looked at the real world evidence, observational studies. Let's look at real cases like Alfie. The evidence on the real world basis is overwhelming, but they said it doesn't count. That doesn't count. The only thing that's any good is a double-blind placebo-controlled study. So and we don't know the side effects of the stuff. We do. I mean, cannabis has been used for over 5,000 years. It's used by 164 million people on this planet every day of the week. I think now, if there was really serious side effects with cannabis, we probably would have got the drift of it by now. There was some, I have to say the word idiot, on the Health Select Committee who said, we don't know enough about this, it might be the next thalidomide. Well, of course it's not. It's been used for thousands of years. We'll have known if it causes thalidomide-like problems. So I don't get that argument. I think underneath the unsaid argument, I think it has to be the stigma are still associated with cannabis in the eyes of generally the older generation of doctors who control these societies. It's been illegal. It's got a view of anti-establishment, hippie, anti-social. I think there's still that reefer madness campaign. I think there's still that thing in people's minds. It cannot possibly be a useful medicine. We don't want children getting high from it. And, there's a lot of remarkable ignorance because you don't get high from medical cannabis prescription, full stop.
No. Let's just walk back through a couple of those other issues. Let me get my head around this issue that you can't undertake research upon cannabis as a pharmaceutical solution. You have to look at it as a plant. What's the difference and what's the relevance of that?
Well, if you take a new pharmaceutical, a big pharma company producing a new product, but let's take brilliant for your blood pressure. Let's take that. It's usually one chemical, and it's easy to compare one chemical with placebo, no chemical. And the patient takes it. The doctor doesn't know what he's giving, he or she's giving. The patient doesn't know what they're taking. And you measure the blood pressure after the tablet and after the placebo, and does the new compound reduce blood pressure? Simple. One compound. Cannabis is not one compound. Now, those people I mentioned earlier, GW Pharma, have taken isolates. They've taken one compound, like CBD, and compared it to placebo. You can do that. That's fine. But it's not the plant. The plant contains 147 cannabinoids, like THC and CBD. It contains over 100 terpenes, which give it its smell, but also add to its medical properties, and 100 other things called flavonoids, which give it its color, but also add to its medical properties. Now, you put that together, and there are tens of thousands of different combinations in any individual plant. And you cannot compare that to placebo. How can you? There's too many variables. You haven't got one variable. You've got several hundred variables. And also, how do you get a placebo cannabis plant? It smells, strangely enough. You can't relatively disguise its taste and its flavor and its aroma. Okay, you can. That's an issue. Maybe we could overcome that issue, but I think it's very difficult to overcome it. So basically, you cannot treat the plant, any plant, as a pharmaceutical single molecule product without destroying the value of the plant as a whole. And that's what they don't understand.
I've got you. So then you move to this issue of real world evidence. And what you were basically saying, Mike, was, if cannabis was, for example, the start of the opioid crisis or whatever it would be, we would know, which anecdotally makes a lot of sense to me. I mean, you would think so. But in all fairness, do we need studies to back that up?
Yeah, I mean, it's when does anecdote become evidence? Is about that. One person says, I had serious pain, I took cannabis and I was better. Okay, that's interesting. I'm not doubting its truth, but it's one person. If 10 people say that, okay, we have to take that a bit more seriously. If 100 people said that, yeah, look at, several thousands of people saying that, and that means something. So when do you say that anecdote ceases to be anecdote and becomes evidence? Then you can do observational studies. You can just simply follow people and see what happens before they take something and after. I mean, that could be on one patient or it can be on hundreds of patients. Take Alfie, you follow him along, you just measure do nothing but measure his seizures, 300 to 400 every week, go on and on, week after week after week. You introduce something, bang, cannabis, seizures stop. And you're not going to tell me that's nothing to do with the cannabis you just initiated? Is it pure chance they stopped at exactly the same time? Of course it's not. I mean, no one in their right mind would suggest that somehow. So they're the sort of studies we need. Observational studies of people, N of one they're called, when you look at one person and follow them through. There's lots of different ways to look at that evidence in a robust statistical way. I mean, there's a thing now in cannabis called the 2021 program, which I won't go into the detail of, but basically it's observational study. It's following at the moment over 2,000 patients who've taken cannabis with proper outcome measures, scientifically valid. We look and say their quality of life is measured, their pain is measured, their anxiety is measured, and it's followed through. It measures before they take it and after they take it, properly statistically analyzed. It's a properly solid scientific piece of ongoing research, but it's not a double-blind placebo-controlled study, but it's perfectly valid. And that's the sort of thing that we need to take account of. And, evidence on that sort of basis is pretty overwhelming now. And I'm not going to sit here and say cannabis is right for everybody and cures every condition known to man. Of course it doesn't. But let's look at the solid evidence base we've got for some conditions for some people.
So effectively what you've described, Mike, is that this isn't so much just a cannabis issue. It's the way in which medics are prepared to interpret different types of study.
Exactly. I think some of my medical colleagues need to move out of the pharmaceutical model. And we've got, remember, of course, medicine was all plant medicine up to about the 1930s. So all doctors, there were good doctors in the 18th, 19th centuries, of course there were, but they had to rely on that sort of evidence. They relied on plants. It's only the pharmaceutical industry that has really changed our mindset about what makes a good medicine. And I think the pendulum, quite rightly, has swung to good science, but it's swung, in so doing, it's swung away from good non-pharmaceutical science. Let's look at pharmaceutical science. Absolutely. Big pharma has changed medicine in this world, mainly for good. But let's not forget the botanical side of plant, which of course big pharma was originally based on plants, developing medicines from plants. Let's not forget that. And let's just embrace the totality of evidence we've got in front of us, from pharmaceutical on one side to plant on the other, and a mixture of the two in the middle. And that's, I think, some of the doctors these days are just swung into a pharmaceutical paradigm and can't get their mind out of it.
Yes, I mean, just on that practical side, if someone is listening or watching who, for example, has a child who suffers from epilepsy and they go to their GP, it sounds to me not so much that they won't be prescribed cannabis because there is a empirical decision that it's not appropriate, but simply because they won't accept the empirical evidence that supports it.
That's right. And what I want to see, I don't want every doctor prescribing cannabis. There's specialties in medicine, gynecology or cancer or neurology. Let's leave it to some cannabis physicians to prescribe it or properly trained. But I think it's the obligation of every doctor in the country, at least to understand the basics of cannabis and give an informed decision. If a patient comes in and says, will cannabis suit my condition? They need a proper, sensible, balanced argument, not a knee-jerk argument that says, no, don't be ridiculous, go away. You're going to get high from that. It's not going to do anything else. And I hear that all the time, that doctors are ignorant about cannabis and its benefits and just have a knee-jerk stigma, reefer madness type response. And frankly, that's not good enough.
No. What does someone do then if they do hit that barrier, but like Hannah, Alfie's mum, they do their own research and they can see benefit in moving further along the clinical process? Is there a particular organisation? Obviously, I know that you're chair and involved in a number of organisations. Is there a particular organisation that they should approach to gain access to a clinician who will think about the suitability of cannabis for them?
Yes. Doctors who are interested in the field generally belong to the Medical Cannabis Clinician Society. They've got a very good website and some of their booklets and information are available publicly. Gives you a bit of background. You can go online now, just Google cannabis clinics, and there's now, I think the number is 18 cannabis clinics in the country. Some of those produce very good information about, is this suitable for me? Of course, some would say, well, they're biased because all they want is the private patients. Yeah, sure, we want it on the NHS, but nevertheless, they do provide that information, and hopefully they have honest doctors amongst them who can then give a sensible, balanced opinion for you and your condition. This might be helpful. That's another way of doing it. And of course, there are also patient support groups, which we shouldn't forget, that provide totally unbiased information because they're not part of a private clinic or anything else. The two I mentioned is MedCan Support. He's one for the families of children with epilepsy. They have I think it's about 500 members now, MedCan Support. There's one called PLEA, patient, I forgot what it stands for, forgive me, but it's called PLEA, P-L-E-A, and that is an advocacy group for patients, and they can provide you information of how to go and get it and the process behind doing it and everything else.
Well, we put those on our socials and in the description on the podcast platforms. And if people want to access them, I'm sure they'll find that ever so helpful. Let me just play devil's advocate for a time, Mike. People are worried about the risks involved in different types of drugs. And when I had a quick look at the UK NHS, National Health Service website earlier, and I mean, this is referring to some potential side effects of cannabis usage, like psychosis, like paranoia, like I'm sure it says increased anxiety, nausea, insomnia. I mean, it was a pretty worrying charge sheet. How does that stack up with the evidence, both in terms of the studies and in your clinical experience?
Yeah, well, I think what we need to bear in mind is that there are really two cannabis types across the world. And let's take the UK. There's medical cannabis, prescription cannabis, and there's street cannabis. Now, over the centuries, street cannabis has been bred to be very high in THC, the stuff that gets you high, and very low in everything else. Now, THC by itself in high doses can cause problems, and those NHS websites is absolutely right. In vulnerable people, it's actually quite rare, but in vulnerable people, it can cause psychosis. In higher doses, it can cause anxiety. it can both help and impair sleep in some ways. So it is associated with problems. You can be dependent on it like you can with alcohol or tobacco. But we shouldn't forget that we're talking really, it sounds a bit odd as it's the same plant, but we're really talking about a different product. That's high THC street cannabis. Also, you don't know what's in it. If you buy it from a dealer on the street corner, how do you know what's in it? Is it pure? Has it been adulterated with anything? You don't know what you're getting. And I think a lot of the press and a lot of the hierarchy bodies even confuse that, which is not straightforward, not entirely safe, with medical prescribed cannabis, which is lower in THC and higher, particularly in the other cannabinoids that don't get you high, like CBD and others. And CBD counteracts the high of THC. So any sensible doctor prescribing it will prescribe initially a product high in CBD, and that may be enough. Like children with epilepsy, they might want CBD and nothing else. And if they need a little bit of THC, because THC is quite useful medically, they introduce it slowly but surely onto the background of CBD. And getting high on a medical prescription is, I can't say it's totally unknown. It would be silly if I said that, but it's very, very rare. I was talking to a friend of mine called Danny Gordon, who's a Canadian prescriber. She has prescribed over 3,000 patients now. She hasn't encountered one case of psychosis in a medically prescribed patient. And that's because it's high in CBD and low in everything else, and low in THC. So, I think the side effects you mentioned are correct, but they're correct in terms of street cannabis. They're not correct in terms of medical prescription.
So the key then, therefore, you would say, is to take this medicine, this solution off the streets, to properly regulate it, to put it in the hands of clinicians, and to educate those clinicians as to the benefits.
I think absolutely right. I would put education my first, second, and third priority. I think it was Tony Blair that said education, education, education. Let's educate the doctors and the public to an extent about what to do. At the moment, the present system is all it's doing is increasing awareness of cannabis and its usefulness, but driving people to the black market because they can't afford it. Which, so ironically, talks like this are probably increasing the profit for the criminal fraternity, which is ultimate irony and remarkably stupid.
Yeah.
Let's educate the public. Let's educate the doctors particularly. Let's get safe products into the hands of those doctors, because the medical products are safe. They're grown to a very rigid standard. We know what's in it. They have what's called certificates of analysis, so they're not contaminated with things. Let's get those safe products into the hands of the doctors, hands of the patients, free through the NHS as the law required back in 2018. A different argument, different discussion about adult use, recreational cannabis, which I've never really got into. I don't want it to sort of confuse the issue of medicinal cannabis. Different argument. But for medical use, let's get it off the streets, for heaven's sake.
Well, yeah, as you've just correctly said, we're talking medicinal cannabis usage today. However, it would be remiss of us to ignore that society element or the wider legal elements. It's a fair point. Your paper, your report in 2016 focused on those 5 conditions that we looked at the outset. But you also made reference earlier to potential help with Crohn's disease, potentially cancer. What about if someone is a cancer patient and they're listening to this and they are being met with that same sort of shutters down approach by their treating consultants or the GP? Would you be saying to them, well, I think this is something you should look into more via these resources to which you referred earlier, Mike?
Yeah, I would. 2 things to say about that. First of all, cannabinoids generally, the product of the plant, many of them have anti-cancer properties. Of that, there is no scientific doubt. In animal models, particularly, and in test tubes. I'm not going to say that cannabis in its prescribable form has anti-cancer properties for man. It does in certain types of cancer, particularly, for example, a particular type of brain cancer called a glioblastoma. Yeah, and there's reasonably robust early evidence they may actually help the cancer. But that evidence at the moment is pretty thin, and I'm not going to say if you've got cancer, take cannabis at all. If I had terminal cancer, I would probably have possibly some pain, certainly anxiety, certainly poor appetite, certainly problems sleeping, almost certainly. So we shouldn't forget cannabis is really a symptom helper, not a disease curer. And for symptoms of cancer, it can be remarkably helpful in the latter few months of your life. You want to sleep better, you want a decent appetite, you don't want to be in pain, you don't want to be anxious. So I would, if I had cancer, I would take cannabis, and they're definitely going to help my symptoms. If it helps my cancer, great. That's an added bonus. So a lot of people write to me and I say to you, don't take this on the assumption it's going to help your cancer. It might, but it's not likely to. But it should, in most cases, help your symptoms. So that's what I say to cancer patients. And push that to your GP or your oncologist, your cancer specialist. You'll probably get an answer, as we've discussed, that's a no, don't be ridiculous. If that's the case, sadly, at the moment, and you can afford it, the only way to get it is through the private sector. And a sensible private clinic doctor will give you, hopefully, that same answer.
It's just so concerning, isn't it, that there's such an inequality of opportunity in terms of accessing that diversity of advice. And I just sympathise so much with someone who goes to their GP and is sort of kicked out, so to speak, on the basis that it's a ridiculous idea. And if someone's got a child who's suffering from epilepsy, I mean, surely us providing access to the full range of medical advice, it goes beyond just good clinical care. We're a civilized society.
It's crazy. And I know, again, Hannah wouldn't mind me saying, she went to a neurologist that she used to see in Birmingham. He said, if you mention cannabis to me again, I'm going to refer you to social services. That's the depth of ignorance and stupidity that she swapped. She got rid of him and moved to another neurologist in Oxford who was more attuned, but still couldn't prescribe it. But nevertheless didn't say that. So, I think doctors do have an obligation, a duty of care to their patients to give them a sensible, balanced, educated answer. And sometimes that answer is no. But let's do it from a sensible, educated, evidence-based point of view, and not out of ignorance and stigma.
Yes, just continuing on this devil's advocate theme. I suppose there's some who could say, well, okay, that is persuasive, but aren't we at the top here of a very slippery slope into other potentially harmful drugs being demanded for clinical treatment whose risks are higher? I'm thinking in particular here, Mike, of the opioid crisis in the US. Obviously, you made the point earlier that cannabis has been available as a medicine for longer there. Do you see any risks that we could, in the UK, for example, go down that road?
No. I mean, I can't see any relationship between saying, yes, cannabis might be right for you and other drugs that might come along. Some of those drugs that might come along, and we're speculating here, may be harmful, dangerous. Others may be useful. Let's just have an open mind of botanicals generally and fungi. Let's not forget the psilocybin, the magic mushrooms that they're called, coming along, and certainly good evidence that emerging for helping depression. Not my subject area, but let's look at these. What I'd love to see is a proper, sensible, scientific body like NICE, but from a botanical NICE, if you could see what I see. It's not a pharmaceutical NICE. Look at the evidence that's coming through for all of these new products. Assess it sensibly in a balanced way and come to a sensible decision. And I think opening the door for cannabis doesn't open the door, shouldn't open the door for anything else that's coming along. And I think that argument I have heard is basically ridiculous. Let's assess each one as it comes along and not dismiss one because, we're opening the door to lots of different drugs here. I mean, that's crazy, isn't it, really?
Well, I think it is. I mean, I suppose also it's the extrapolation of this confusion between a medicine and a street drug, because it could be that on the street, use of cannabis, because you're mixing in drug-taking circles or with dealers, it could be that that's an element of slippery slope, but that would tend to support your argument to get it off the street.
It would, wouldn't it?
Yeah.
It would. Yeah. I mean, I don't know, but I'm sure you go to a dealer, you don't know what's in the cannabis you might be getting. Somewhere it's probably very good quality, somewhere it isn't. And the guy might say, well, have you tried these tablets as well? So cannabis is not a gateway to other drugs, except by the fact of how you get it. the gateway might be there to the dealer who wants to flog you something else at the same time. And in my view, that's a reason to take it off the street. And people are going to use the stuff. Let's not forget, in this country, 1.4 million people use cannabis for medical purposes, not recreational, medical purposes every day. Those people are going to keep using it. So for heaven's sake, why don't we get those people into a safe system where they don't cost money? It's free because it's NHS and the government has said we want it free. And let's take those 1.4 million people out of the streets. Why on earth are we lining the pockets of the criminal fraternity when it's a decent medicine that should be available to all who need it?
I want to come to this when we wrap up, Mike, because I think this is relevant, isn't it, to the future where we might go with this in terms of the potential to shape a lawful and officious cannabis sector in the UK. So I want to come back to that. But I just wonder if we could open the debate out a bit here, because the reason I started this podcast was partially because I felt that when I was interested in a subject and I reached out into the digital world to try and find evidence, answers, expertise, I was noticing some very strange sort of trends. And this is very topical at the moment. Jacob, I'm just talking to our producer. I sent some links to you before on this. I don't know if you're aware of this, Mike. Joe Rogan, who is a very popular podcaster in the US, and he's got a popular podcast throughout the world. He's become embroiled in some controversy recently. I just very quickly, Jacob's just going to flick through the various slides in a moment. What happened was Joe had a couple of medics onto his podcast talking about the efficacy and the risks involved in the COVID vaccine. A number of people, typically celebrity. There was Neil Young. There have been other musicians and celebrities who have come out and attacked Joe, accusing him of spreading medical misinformation. You then have had one or two celebrities again come out and defend him. I know Dwayne Johnson, Jacob, he's one, isn't he? I think I sent you that link. It was Dwayne Johnson, wasn't it? He came out and basically said his explanation was fair enough. Yeah. Oh yeah, there he is. Yeah, he said, Joe, fair play to Joe. We then, and I guess this is the part which worries me most, we've then had various media outlets. I think I sent you, Jacob, The Guardian, maybe the new, here we go. It's sort of, these media outlets who've come in as like a fact checker. They've come in, and this could be a science correspondent, it could be a journalist, and then finally we've had Spotify come into the debate, and they're having to make business decisions now on how they structure their platform, which is huge, the Spotify platform, on the basis of all this noise. So me as just an ordinary person who's trying to navigate their way through life, making reasonable risk-based decisions for myself, for my family, for my business. The reason why I enjoy conversations like this is because we have, it seems to me, just like an endless number of resources to examine evidence, examine theories, examine risks, but we're being dragged through those resources to conclusions and echo chambers where the right answer, or even a reasonable answer, isn't being reached. I think that creates a degree of groupthink, because, for example, if you read those articles criticizing Joe Rogan or supporting Joe Rogan enough, then the social media algorithms will keep feeding to you different articles and resources which will enforce those views. And as I say, that creates a degree of groupthink. That's the problem I've got in terms of, and that doesn't just happen in the medical world, it happens in the business world. But first of all, just on the medical perspective, how do you think we need to, do you think we need to make any changes to bring scientific evidence and empirical data to the forefront of debate around those complex issues?
It's such an interesting discussion at the moment. And I think there's a lot of positives about social media. It's enabled people who didn't really have a voice. Look, before social media, the only source of medical information was to go to your doctor and ask him or her. You couldn't really do anything else. You could look up Encyclopedia Britannica or something, I suppose, but that was your lot. So now at least you can access very quickly a massive amount of information. So in one sense, that's good. And we shouldn't forget the cannabis movement has been largely patient-driven, and I think that's great. It's the patient groups that have pushed the change in agenda through social media. The downside, as you quite rightly said, social media, is that how does the person who's not very educated in that field differentiate rubbish from decent information? I'm all for a debate. There's people who are pro-cannabis and people against cannabis, but how do you get those who are pushing the debate one way or the other on a basis of fact? So intelligent people out there can make their own mind up listening to sensible arguments on both sides. And the trouble with social media, there's not a sort of sensible filter. You need a common sense algorithm filter. This is utter nonsense. Should be rated. 1 out of 10, this is just rubbish. 9 out of 10, take notice of this. I don't know how the hell you do that. I like the fact check. Some of the national newspapers, as you've said, do have fact, and indeed the social media have fact checkers, mainly for politicians who come out with all sorts of rubbish. He says this, and actually the truth is that. I'd love to see a more sort of automatic fact checker. Cannabis doesn't cure all cancer. That's nonsense. 1 out of 10. Cannabis causes major psychosis in everyone who takes it. Nonsense. 1 out of 10. Let's have some sort of balance in social media. How the hell you do that, I have absolutely no idea. But you've somehow got to balance the good things about social media and what is a lot of nonsense on social media, a lot of damaging nonsense. What I hate is people who come out with one opinion, get totally vilified for that opinion. Perhaps I sound old-fashioned at this point, but a little bit of good manners on social media doesn't go amiss either. So I've been vilified on social media many times, and it's very unpleasant. And so you tend, the voice of reason, I'm putting myself up as the voice of reason, aren't I? But I'll keep going with this argument.
Please do.
Is silence.
That's great.
I don't want to. Why do I want to go on social media for somebody that's going to say I'm talking a lot of nonsense and I'm doing this to make money and I'm capitalizing on the poor children to make money and line my own pocket? I've had all that thrown at me, and it puts you off doing it. So my view is lost to social media because I don't want to put myself out there for all that. So all you get are the raving lunatics sometimes.
Well, I mean, it's interesting, isn't it? Because of this issue of echo chambers forming due to the social media algorithms. And when I was just planning for the podcast, and obviously because the Joe Rogan controversy is so topical at the moment, I was thinking, well, hang on, can you be accused of hypocrisy here? Because you're talking to a very eminent expert in this issue of medicinal use of cannabis. But it sounds to me that if we brought in the Pediatric Neurology Society, they would have a contrary view and they would probably be prepared to justify their position. And that, of course, brings this issue of where do ordinary people go to find out what is reasonable, balanced argument? Because I'm not an expert in this area, and I don't feel that it's practical, for example, for me to hold this podcast and have all sides of the argument represented at once in a way which allows everyone the same time, the same level of scrutiny. Yeah. But then at the same time, I'm thinking to myself, well, if there's no independent arbiter or fact checker of anything, then there's probably an obligation on us all to present a bit of a balanced view. The only conclusion I can come to, Mike, is that we have to encourage rational debate. We have to encourage discourse. And if that's why podcasts are popular, that we have a little more time than, for example, just in a TV interview or the clickbait of social media. And I think as long as we all welcome rational debate and other points of view, we've got a good chance of reaching reasonable conclusions.
I agree with you. And that's what's nice about podcasts. We've been talking, for an hour and 10 minutes or something, hopefully reasonably. And people can say, I like that argument. I didn't like that argument. And I'm more than happy to debate these things with the people on the other side of that argument, like the BPNA. Trouble is, a lot of these people won't engage in that debate. I don't know why. So yeah, that's why I think the strength of podcasts above the 30-second soundbite on television news or radio, or maybe the biased article in a newspaper. It's, I think this is a medium through which we can have sensible, balanced, rational debates, and people can make up their own minds.
Yeah, I think so. I mean, I want to ask you about the future in a moment, but just to finish off on this point of the possible negative effect that these sort of echo chambers can present, that are arguably contributed to by social media and maybe the media generally, just taking it away from medicine. Part of my role as CEO of the Spiring Group is to, from time to time, to raise investment for our business plan. And the sectors that we operate in, principally legal and tech, have had some well-publicized business failures, which have been disastrous for investors. And what I've found occasionally is that you won't get past an investor's front door, not on the basis that you don't have a good business or that the evidence and the data you've got to support the strength of your business isn't sufficient, but they purely refer to, well, but did you see this all over social media, that this tech business has failed disastrously? And this is a real problem in how organizations in society take risk. They don't actually assess specific risk. They adopt groupthink. And I'm worried that unless we can find the solution to this, and I've not heard anything better than a continuation of rational debate, I'm worried that groupthink will slip into all parts of business and life.
I agree with you. And the same's happened in the cannabis sector. We've had people, there have been some spectacular failures, not surprisingly, in a new market from cannabis investors, and that's got a lot of publicity on social media. We've had some issues with some of the cannabis dispensaries in this country, where there have been some issues of supply. And we've had an investor recently who's looked at these and said, well, I'm not investing in this space because look at the stuff on social media that's against it, without realizing that may represent, it may be true, it represents 5% of the difficulties and 95% of people are very happy. So, you're quite right. I would encourage investors to look broadly. Don't just look at social media. Don't look at Reddit groups and things like that, or look at them, but then balance it out as best you can. And that the problem is it's difficult sometimes to balance it out as good as you can.
Yeah, I think that's right. So let's think about the future before I let you go, Mike. What's next for you, and what are your hopes for the application of cannabis as a medicine, and perhaps any sector that can develop around it?
Well, I'm a stubborn optimist. I don't think I would have survived in this field for the last 5 years without being an element of optimism. Cannabis is here to stay. There's no doubt. Look, worldwide, 55 countries now. It's legal for medical purposes in some shape or form. It's here to stay. It's a big industry, big business. We should look upon it. Of course, it brings jobs. I mean, we did a paper recently through Maple Tree that looked called 10 Recommendations for Government, which thought there would be about 100,000 jobs if we developed a proper cannabis industry, let alone several hundreds of millions of tax income. So purely on economic grounds, I'm optimistic. I think at some point, the government, post-Brexit, post-COVID, will think, actually, we could do with a new industry here that's going to create tax income and jobs. Ignore the medical benefits. If that's, politicians, bless them, would tend to take much more notice of jobs and tax income than the medical benefits. But if it is a good industry that also gets medical benefits, they should embrace it. So I think I see cracks appearing, and there's cross-party support in Parliament for this. It's not a party political issue. We need the government to say, hang on, we changed the law. The medics haven't embraced it. There's things we can do to encourage it to be easier and less bureaucratic. Let's embrace this industry and go forward. And, it's medically, it's here to stay. There's more papers coming out daily, thousands a year now of its benefit and its downside. They're not all going to be positive papers. Let's look at that. Let's try and educate the doctors. That's what I really want to see in the next few years for the future. Educate the doctors so they come up with a reasonable, informed opinion and not a knee-jerk, this is rubbish, stigma opinion. That's what I really want to see. So I'm going to stay here until we've educated the doctors and we got it on the NHS. And we'll get it on the NHS. I think we'll get it on the NHS within 3 years. So ask me back, Simon, in 3 years, and you can tell me, you talked a lot of old rubbish 3 years ago. It's still not available. Or you were quite right. Look at it all now. So there's a challenge for you. Ask me back in 3 years and we'll see if I'm right or not. But I think we'll be home and dry in 3 years' time.
Well, we certainly will invite you back in 3 years. And whether this expansion in the NHS proves right or not, you certainly have not talked a lot of rubbish today, Mike. It's been so interesting and so helpful. So I want to thank you for your expertise today. I know our audience will have gained some value from this, and we'll include the resources that you've mentioned on our website. I want to thank you very much for your company as well. It's been a real pleasure talking to you, Mike, and I wish you all the very best.
That's great. Thank you very much. Thank you for asking me. It's been a pleasure.